Now we will move on to the second session. To chair the second topic, I am pleased to welcome Dr. Venkatraman. Dr. Venkatraman, consultant diabetologist from Apollo Hospitals and Surya Hospitals, Chennai. Dr. Venkatraman is an active speaker and chairperson in many national forums. I welcome Dr. Venkatraman to the dais to do the proceedings.
So good evening, everybody. At the outset, I think I would like to profoundly thank MSD for this opportunity to be in the midst of my friends and galaxy of speakers for this excellent symposium. I think as a brief introduction, it will be pertinent to point out that till the early part of this century, when we as clinicians realized that good glycemic control in the early part of the disease is of paramount importance in preventing the vascular complications, we always used to tell ourselves and also remind our junior colleagues that an ideal oral anti-diabetic drug should be. I mean, at that point of time, only the sulfonylureas were the major players from the secretagogue correction point of view. So an ideal oral anti-diabetic drug should be capable of facilitating insulin secretion when there is hyperglycemia, switch off the insulin production when the sugar more or less reaches the euglycemic level, try to address the issue of weight gain, and possibly target the hyperglycemia. This was a wishful expectation of the clinicians across the world when we realized that good glycemic control is of paramount importance, and to be handy to us for use in this scenario to fulfill these aspirations, we had the first DPP-4 inhibitor, that is the sitagliptin, and subsequently many DPP-4 inhibitors have been introduced. So the last almost a decade of their usage has thrown a lot of light, not only about their mechanism of action, in what clinical scenario you're able to use these molecules, and also the extra glycemic benefits that these molecules offer to the clinicians. I think to elaborate more on this interesting subject, we have Dr. Avdesh Kumar Singh from Guwahati. He is a chief consultant endocrinologist and diabetologist from Sun Valley Diabetes Research Center and Hospital, Guwahati, and he has immensely contributed to various journals, peer-reviewed journals, and also in textbooks of diabetes. He has got about 25 publications, and an eloquent speaker, most sought after in most of the national meetings. Dr. A.K. Singh.
Thank you, Mr. Chairman, sir. Thank you, Dr. Krishna, organizers, for inviting me to such a grand place. My topic is a little bit different in the sense it fits into the actual science of trendo, emerging trends in endocrinology and diabetes. So in this 20 minutes, what I am going to talk today is to tell you a fascinating emerging aspect of DPP-4 inhibitor and their mechanism of actions. Now you'll wonder, what is big deal about that? We all know how DPP-4 acts. And I will give you a little bit of, skewing in the things. What we were knowing may not be exactly correct, and there are so many things to know what is there in DPP-4 inhibitor and why it is acting in a different way. So let's take you some basic idea. We all know that the pharmacological actions of GLP-1 agonists like liraglutide, exenatide, and so many GLP-1 agonists are largely predictable. You inject it, the GLP-1 level goes up, it goes to the pharmacological range, almost 10-fold rise of GLP-1. You don't need endogenous GLP-1. Whether patient secretes endogenous GLP-1 doesn't matter to them if you inject GLP-1 agonist. And they are not susceptible to DPP-4 inactivations. So that is a very clear-cut aspect of how GLP-1 agonist acts. We also know that if you increase this GLP-1 level to the pharmacological range by injecting a GLP-1 agonist, it directly acts on GLP-1 receptor on beta cell and produce the therapeutic effect by insulin release. However, the mechanism of DPP-4 inhibitor is relatively less clear. Why it is less clear? I will tell you. So if you see what happens to the GLP-1 when it is secreted from L cells in the ileum, immediately it is broken down. So you could see 75% of GLP-1 which is secreted from L cells in ileum is immediately broken down into an inactive peptide. The rest 25% actually reaches to the liver. Out of this 25%, again 50% is metabolized in the liver, and only 10 to 15% are left behind to do something in terms of reducing blood glucose. Is it enough? Whether 10% of GLP-1 which is coming out if you give a DPP-4 inhibitor is fine enough to produce their metabolic axons, this is what I am going to talk today. So why it is less clear with the DPP-4 inhibitor? We all know how the DPP-4 inhibitor acts. They act on endogenous GLP-1. So my L cell has to secrete some endogenous GLP-1, then only DPP-4 inhibitor will act. If my L cell doesn't secrete GLP-1, DPP-4 inhibitor classically should not have any axons. But what is interesting is, if you give a DPP-4 inhibitor, the GLP-1 rise are very trivial. If you see the literature, they suggest 1.5 to 3-fold, but this is questioned nowadays. But the rise of GLP-1 will dependent upon the endogenous GLP-1 secretion. So if you differentiate from a GLP-1 agonist, you don't need endogenous GLP-1. For a DPP-4 inhibitor, there has to be endogenous GLP-1 to act, to have a, axons with the DPP-4 inhibitor. But what is interesting is, if you use a DPP-4 inhibitor, whatever gliptins you have, sitagliptin, vildagliptin, linagliptin, sexagliptin, they almost achieve 85 to 97% of DPP-4 inhibition. But what happens to that? The half-life of GLP-1 hardly increases from the 1 minute to 5 minutes. And also if you see their residence time in the circulation, that also remains pretty short. That asks the questions whether this trivial rise of GLP-1 with DPP-4 inhibitor are good enough to engage GLP-1 receptor in beta cell, and this is what I am going to talk today. So this is the background idea, what I am going to tell you, how DPP-4 inhibitor is acting other than GLP-1. So then scientists would like to know whether DPP-4 inhibitor is acting through the GLP-1 receptor. So what they did is, in a mouse model, they knocked out the GLP-1 receptor. They have given DPP-4 inhibitor to the mouse model, and they could see that blood sugar is going down. In spite of having no GLP-1 receptor, if you give a DPP-4 inhibitor, it is still working. That leads a question whether DPP-4 inhibitor is acting through a GLP-1 receptor. So they thought that the DPP-4 inhibitor might be working through GIP receptor. So when you block the GLP-1 receptor, it would be a GIP receptor which would be probably super active with a DPP-4 inhibitor. So what they did is, they knocked out even the GIP receptor. So this is a double incretin receptor knockout mouse, Derco mouse. When they knocked out both GLP-1 and GIP-1 receptor, and they give the DPP-4 inhibitor, then they find there is no substantial reduction in blood glucose. So they concluded that for the DPP-4 inhibitor, you do need GLP-1 receptor for the mechanism of action. Michael Nock and group, and they challenged this concept. So this was the paper published in Diabetologia by Michael Nock group, and they immediately challenged whether DPP-4 inhibitions and their mechanism of glucose lowering is mediated through GLP-1. And you could see these were the 4 conclusions, that it is unlikely that the trivial rise of GLP-1 by DPP-4 inhibitor is accounting for the desirable glycemic effect with DPP-4 inhibitor. Now, another aspect too, very interesting, this is, my paper is under publications, and I tried to collaborate the head-to-head study of a DPP-4 inhibitor versus a GLP-1 agonist. So you could see there are 10 trials here. This is a head-to-head trial of a DPP-4 inhibitor versus a GLP-1 agonist. If you see the lower 4 study in the lower panel, This is the longer acting GLP-1 agonist. Longer means once weekly GLP-1 agonist. And you could easily find out that they have clearly beaten DPP-4 inhibitor in all parameters, whether it's a fasting, it's a prandial, HbA1c, or patients achieving target of less than 7%. So the longer acting once weekly GLP-1 agonist were clearly superior to a DPP-4 inhibitor. But if you look into the upper four study, head-to-head, a study of GLP-1 agonist versus DPP-4, the data is very interesting. See, now our original thought that GLP-1 agonist is much more robust in increasing GLP-1 to pharmacological rise to tenfold, but when you have a head-to-head study of DPP-4 with a shorter acting GLP-1 agonist like exenatide twice daily or with a lixisenatide head-to-head, you can't find any gross superiority of short-acting GLP-1. And in middle column, you could see two head-to-head study with liraglutide. In one study head-to-head with lira, they showed superiority of lira over sitagliptin, but in another study, they could not achieve the superiority head-to-head with DPP-4 inhibitor. This study, and then thereafter meta-analysis done, you could see the Caroline did the meta-analysis, and they could clearly make out that shorter acting GLP-1 agonist was not found to be clearly superior to DPP-4 inhibitor, except the longer acting GLP-1 agonist. This meta-analysis and head-to-head study represents a conundrum that the clinical benefits as measured by HbA1c does not dramatically differ between a DPP-4 inhibitor and GLP-1 agonist. And these are the reasons why we are looking for a newer episodes of mechanism with DPP-4 inhibitor. So what could have possibly happened with this head-to-head study? There could be two possibilities. Number one, whether subcutaneous GLP-1 agonists are less than expected response. Is there any reasons for less than expected response with GLP-1 agonist? This could be one possibility. The another possibility would be whether there is a little more response with DPP-4 inhibitor than what we are expecting. So let's take one by one. What could be the reasons with less than expected response with GLP-1 agonist? So let's see, if you compare with a subcutaneous GLP-1 agonist versus a native GLP-1, if you give an IV GLP-1, it immediately makes you normoglycemic. But if you give a subcutaneous GLP-1 agonist, blood sugar comes down, but not to the normoglycemia. And you have got a unknown, untoward GI side effect. So there is a difference between intravenous and subcutaneous GLP-1 formulations. Even if you give a subcutaneous GLP-1 infusion, you will not get the desirable effect as the IV GLP-1. So what could be the possible reason? These are the possible reasons. If you give through the subcutaneous GLP-1 agonist, like let's say injection liraglutide, Victoza, we only found out a peak GLP-1 which is lasting for 1 to 1.5 hours. If you give a subcutaneous GLP-1, their bioavailability are much lower. You could see the 20% lower bioavailability if you give a subcutaneous injection of liraglutide or exenatide. And interestingly, you cannot use the largest dose of GLP-1 because it produces, the side effect of nausea and vomiting before they could achieve glucose lowering effect. So what could be the possibility that if you give a subcutaneous GLP-1 injection, there could be some modifications in the adipose tissue which probably fastly metabolize GLP-1 agonist which you are injecting. Or there could be a possible interactions between the adipose tissue with the GLP-1 agonist. So these are the proposed theory with less than expected response with subcutaneous GLP-1. And that's maybe the reason why GLP-1 agonists are not looking far, far superior over DPP-4. Whereas, if you look into the DPP-4 inhibitor, they may have some another mechanism of glucose lowering. What are those? So let's go back into a little bit of DPP-4 physiology. There are some DPP-4 substrate which are glucose lowering in nature, of which 3 DPP-4 substrate like pituitary adenyl cyclase peptidase 38, gastrin releasing peptide, and recently oxyntomedulin. These are 3 DPP-4 substrate which have a glucose lowering property. So if you give a DPP-4 inhibitor, you could possibly increase these substrate which have a glucose lowering property, and these are very recently published data. Now it is also thought that if you give a DPP-4 inhibitor, there is an alpha cell mediated insulinotropic effect, because alpha cell also expresses and secretes GLP-1 and GIP, which exert direct action on the beta cell. So it's a very close effect from alpha cell to beta cell. These are the proposed mechanism for DPP-4 inhibitor induced glucose lowering. The another possibility would be to look into the DPP-4 enzyme activity. So if you see the literature here, and in a type 2 diabetic patients, those who are uncontrolled, they have got a very enhanced DPP-4 activity. So if the endogenous GLP-1's half-life is becoming even shorter. So if you give a DPP-4 inhibitor, you could prolong the GLP-1 by inhibiting the DPP-4. So there was a meta-analysis which suggested that there are 33% increased DPP-4 activity in type 2 diabetes. So if you give a DPP-4 inhibitor, this will abolish the 33% increase in DPP-4 activity and could reduce the blood glucose. And this was the study and the meta-analysis published. So 33% increase. Then nowadays we have got some emerging concept in experimental model that DPP-4 inhibitor might be acting through something completely different pathway. How this mechanism occurred, that moment you take a DPP-4 inhibitor and it has not yet reached into the ileum to the L cell to secrete GLP-1, you are getting the response. So it was thought that something earlier is happening before DPP-4 inhibitors are reaching into the ileums to secrete GLP-1. So there are several theories proposed, although these are experimental and need to be proved in clinical scenario, but these are the proposed mechanism. So you could probably are inhibiting intestinal DPP-4 proximal to the site of GLP-1 secretion, and moment that there is a GLP-1 level locally rising in the upper GI tract, even before it is reaching into the ileum, there is a direct gut to brain to cell axis by which DPP-4 inhibitor might be working. There is another possibility, because portal vein and the L cell has got a same innervation, and portal vein has got a highest GLP-1 concentration. So if you give a DPP-4 inhibitor, it is reaching into the portal vein and it is directly producing gut to cell axis effect, which is called portal neural sensing theory. Then it's like a analogy to exogenous versus endogenous insulin. If you give a DPP-4 inhibitor, there is the portal rise of GLP-1. But if you give an injectable GLP-1 agonist, there is a systemic rise of GLP-1. So this portal is to systemic GLP-1 gradient might be doing trick for DPP-4 inhibitor compared to GLP-1 agonist. And this was one of the first study to prove that GIP might be working to reduce blood glucose with DPP-4 inhibitor. Because if you give a DPP-4 inhibitor, there is a rise in the GIP, which directly stimulating the somatostatin, which has got a reduction of intestinal motility, and this is called paracrine theory. Nowadays, very much focus are put on this concept, which is called dipeptide theory, because I will give you a schematic presentations of this dipeptide theory, and there is now a study to suggest that DPP-4 inhibitor may have a direct GLP-1 secretagogue property. So if you give the data is currently with the sitagliptin, if you give a DPP-4 inhibitor, there could be a direct GLP-1 stimulator from the L cell. So coming back to the dipeptide theory, if you look into the GLP-1, this is the active GLP-1, which is 7 to 36 amide. And with DPP-4 enzyme, it is broken down into inactive 9 to 36 amide and a dipeptide, which is called histidine and alanine amino acid. Same happens with the GIP, and there it is called tyrosine and alanine. This dipeptide has got a gluconeogenic property. So if you give a DPP-4 inhibitor, you are abolishing the effect of this dipeptide, and probably this would be one reason, exciting reason, how DPP-4 inhibitor might be acting to reduce blood glucose. And just to simplify what I have said into this experimental animal, this is the classical concept of a GLP-1 induced blood glucose lowering. But if you take into account moment the food in the upper GIT, it doesn't need to go into the ileum to secrete GLP-1 from L cell. They directly activate the central nervous system to have a direct effect on beta cell. So this is gut to brain to cell axis theory. Another was, I was telling, that food in the upper GI tract, the portal's GLP-1 is higher, directly stimulating the beta cell, bypassing all this classical GLP-1 related mechanism. These are emerging experimental evidence with DPP-4 inhibitor. So to summarize what I have said, the action of DPP-4 inhibitor appears only partially dependent upon overall GLP-1. It is required. But there are several factors like, as I said, directly alpha cell mediated response, oxyntomedulin, pituitary adenyl cyclase, portal GLP-1 gradient, GIP as I suggested, and this dipeptide theory, and possible some other, maybe next year when I come back here, I would talk about something new about that, many unidentified substrate which probably also would be responsible to mediating this glucose lowering effect. Thank you very much for your patience hearing.